and welcome to another Top Doctors online interview with one of our leading specialists. Today, we are so honoured to be joined by Professor Stuart Bloom, a London-based leading consultant gastroenterologist. Thank you so much, Professor Bloom, for joining us today. We really appreciate you taking the time. Would you like to introduce yourself?
Yeah, fine. Thanks very much, Lauren. So I'm Stuart Bloom. I am, as Lauren has already said, a consultant in London. I work at University College Hospital, where I was appointed as a consultant in 1996, so a few years ago. And I spend my time seeing patients, mostly but not exclusively, with inflammatory bowel disease, doing endoscopy and running the inpatient and outpatient inflammatory bowel disease service at University College.
Perfect. Thank you so much, Professor Bloom. So today we're going to be speaking about ulcerative colitis. I believe you've already done a podcast on Crohn's disease, which I'm sure we're going to briefly touch on as we move through this. But what exactly is ulcerative colitis?
Yes, Lauren, thanks for the question. So ulcerative colitis is a disease of the large bowel called the colon, first described over 100 years ago. We've known about it for a long time. Lots of things we don't know about it, as I'm sure will come out in a bit. Anyway, it's an inflammatory disorder. It affects the colon. That's the lower part of the bowel. It only affects the internal lining, the mucosa of the colon, unlike Crohn's disease. Again, we'll come on to that, I think, in one of your subsequent questions. It's quite common. It probably affects about 250,000 people in the UK. And it can affect old and young. I mean, by young, I mean, literally children, almost neonates. And by old, I mean that we have patients in their 80s and even 90s with colitis. Men and women. It can be devastatingly severe, or it can be rather mild. So it encompasses a big spectrum of disorders across different age groups and different levels of severity.
Perfect. Thank you. Very insightful overview of the condition. So how, you briefly mentioned this in your answer, but how is it different from Crohn's disease? Are there any similarities?
It's different from Crohn's disease because it affects the internal lining, that's called the mucosa, whereas Crohn's disease tends to go right through the whole of the wall of the intestine. And what this means is that Crohn's disease can rather unpleasantly cause connections between adjacent loops of bowel or tracts of infection in the bowel to other places, including the skin and various other places. Colitis doesn't do that. It's just limited to the internal lining of the colon. The other way in which it differs from Crohn's disease is that, as the name sort of implies, it's a colitis. It only affects the colon, the large bowel, whereas Crohn's disease can affect not just the colon, but the small bowel and even the stomach and the duodenum and other places. So colitis is limited to the large bowel.
Perfect. Thank you very much. And what causes ulcerative colitis?
Now you're asking. So if I knew that the answer to that question, I would tell you on my way to picking up the Nobel Prize. We've known about colitis for 150 years. It's not exclusive to humans. There are some animal models. But while we've made a lot of progress in analyzing the abnormal findings in the immune system and in the mucosa, and also in the genetics that can predispose human beings to either colitis or Crohn's, it's also true we don't yet know the cause. The closest I can give you to an answer is on the back of some work that I've done with some scientific collaborators at University College Hospital. We think that something triggers off an inflammatory reaction in colitis. It might be an episode of gastroenteritis or food poisoning. It might be some other event, like maybe a drug or maybe an acute medical event. It might even be an episode of acute anxiety or stress. And once that switch in the body is switched on so that there's inflammation, we think that people with ulcerative colitis have trouble switching the inflammation off. So it's a something triggers off the inflammation and it doesn't stop. It's like a light switch, which once you switch it on, it won't switch off. That's the closest I can give you. As will, I think, become apparent later in the questions, our treatment is directed at controlling that inflammation rather than completely taking away the underlying cause.
Super, that's fascinating. One question that comes to my mind when I hear that is it likely to run in families? So if somebody has perhaps a parent or a grandparent who suffers from it, is it likely that their body might be pre-wired to be unable to turn off the inflammation as well? Is that possible?
That's a great question. And there is a genetic link. It's not a direct link. It's not like some of the single gene disorders that if you have the misfortune to develop, you know that you might pass them on to your children. It's not that simple. It's not one-to-one, but there is an increased link, and it's not just colitis, it's shared with Crohn. So inflammatory bowel disease does have a family association, and there is a genetic component. That's one of the ways that we were led many years ago now into looking at some of the genetics of colitis and Crohn's. So there's a bit of a family link, but it's not 100%. You've probably got a 10% chance of that order, that if you have colitis or Crohn's, you'll have a close family member, maybe brother, sister, aunt, uncle, parent, child, that might be affected with one of these diseases.
Perfect. Thank you. Very interesting. The next question would be, what are the common symptoms of ulcerative colitis?
Yeah. So the hallmark of ulcerative colitis is blood and diarrhea, or bloody diarrhea. So pretty horrible. You go to the loo, and your normal, poo once or whatever, however long. Normal range is every 3 days to 3 times a day. Not everybody knows that. What happens is you pass some kind of combination of loose stools and blood. Now, if the colitis is just limited right down to the lower part of the colon, the rectum, you must have some bleeding. There's a condition, it's called proctitis, where just the rectum is inflamed. And that can just present with a bit of discomfort and a bit of bleeding. Whereas if the whole of the colon's inflamed, then it's a bit like, if you can imagine a really nasty case of sunburn with your skin weeping fluid. Well, inside the colon does the same thing. So it leaks a whole load of blood and sort of serum, and you get a sort of mucousy, liquidy, rather unpleasant diarrhea with some blood mixed in with it. Bloody diarrhea is what
it certainly doesn't sound pleasant. I'm sure if anybody presented with those symptoms, they would most likely immediately seek medical attention, you would hope.
Yeah, mostly true. Most people are armed when they're with those symptoms, and you can get some pain. Curiously, pain isn't often that much of a feature. Some discomfort, maybe some intestinal sensitivity to food, some hurrying to the loo and so on. But as I say, it's really blood and loose stools.
Perfect. And interesting you should mention food, because my next question that I have prepared is, what foods should be avoided by people who perhaps have ulcerative colitis?
Yeah, this is interesting. If you look in the textbooks, there isn't much there that says that food makes colitis worse, but I don't believe that. I think there's some relation. So the first thing to say is that because you lose the lining of the colon, the mucosa, you can become lactose intolerant. So that means so a lot of people with ulcerative colitis will get gas, bloating, liquidy, loose stools with dairy, and they'll feel better if they avoid dairy products. That's the first thing. And then after that, it's a bit more opinion rather than evidence-based. I think it's pretty widely agreed that if the colitis is very low down, it just affects the lower part, the rectum and the sigmoid colon, then you can get a sort of a build-up, you can get a bit of constipation above that inflammation, and too much fiber or too much insoluble roughage or the vegetable fiber can make things worse. And that's not widely appreciated, but after 35 years or something looking after the condition, I'm pretty clear that in people with just a distal colitis, I would certainly advise some caution about taking too much fiber. It depends on the individual, it depends what symptoms they have. But often if they are a little bit constipated because they've got a build-up of poo above the inflamed bit, then eating food with a lot of fiber won't help. Apart from that, I wouldn't say that any particular foods are contraindicated or cause problems. I mean, I guess you'd need to be worried about alcohol, which can cause a bit of diarrhea sometimes normally, and too much in the way of sort of spicy or very hot food, which might just won't be as well tolerated as they might otherwise be.
I can imagine. Perfect. Thank you very much, Professor Bloom. So apart from food and diet, is there any other non-surgical treatments or ways of managing ulcerative colitis?
Oh, well, if you're asking me about drugs, oh yes, that's a big area. So I think, though, you asked the question in a very good way, because most of us would want to think about avoiding drugs first. You're absolutely right about foods. Other things which can make colitis worse, stress can make it worse. You may or may not want to ask me about that, but there are some other non-drug treatments that are of interest, and it's one area where complementary therapy has been explored. So we know that some of the complementary healing medicines can have an effect. The two best evidence-based ones are aloe vera and turmeric, and both of those probably have some kind of effect at reducing inflammation. I mean, I'm a bit of a conventional physician, so to me, aloe vera and turmeric, they're drugs by any other name. They just we don't know how they work, but they're not sort of medically formulated, and yet they can have a bit of a role. Would you like me to tell you something about the drugs involved?
Please.
So this could take a long time. So I'll give you headlines, okay? Okay, so the mildest drug that we give for the mildest disease is a drug called mesalazine, which is like an aspirin. It's basically an aspirin for the bowel, okay? The trick comes in how we deliver it to the colon, because if you take an aspirin, it gets digested by stomach acid. So there's a whole load of clever pharmacological tricks, and therefore different preparations that deliver this drug to the colon. And also, because, as I've said to you, the colitis starts at your bottom, then often the best way of getting a drug there is to put it up your bottom and to give it as a suppository or as an enema. Okay, which is just not everybody tolerates very well, but can be very effective. You can mix the two. You can mix the same drug taken orally and what we call topically, which means as an enema or suppository. So that's mesalazine. The next drug would be steroids, which have got, I think, quite justifiably a pretty bad reputation. We don't like using steroids, but generally hate using steroids because they have a whole load of side effects. And they're not our favorite drugs, but they can be pretty effective at controlling inflammation. Okay. Once you've dealt with the aspirin medications and the steroids, then you're into like a much heavier duty kind of medications. Till about 20 years ago, we had about 2 or 3 drugs, which we call immune modifying drugs, which we also use in other drugs, diseases like rheumatoid arthritis and psoriasis and other inflammatory conditions. They're drugs like azathioprine or captopril or methotrexate. And they're not bad. They're old drugs. They work pretty cleverly. They've just been around for a long time. And they had a pretty major role until less so since the pandemic, because the pandemic made us worry about drugs that were suppressing the immune system. There's a big tradition, a big amount of evidence and literature around them, and they still have a place in treating colitis. And then after the immune modifiers, there's like a whole family of drugs, which we call biologic drugs, and which are basically engineered monoclonal antibodies against inflammatory proteins. and they've been around for about 25 years, since the late 1990s. And that's a whole different topic. It's quite complicated. There are some drugs that target a molecule called TNF, so they're anti-TNF antibodies. There are some drugs that target the homing of lymphocytes to the gut, and they're sort of there's a drug called Entyvio and a couple of others being developed which target lymphocyte homing, so they're kind of more gut specific. There's a new drug or newish drug called Stelara, which get another signaling mechanism. And then there's a family of drugs which are very appealing because they're oral rather than injections. And they're also being developed in the last 5 to 10 years. And one of those drugs, or one type of those drugs, are called JAK kinase inhibitors, and there's a drug called tofacitinib. And the names don't really necessarily, they may matter to you, and we can go into it if you want, but it's important to, the message is that we have a lot of different drug treatments, and in most cases, drug treatment offers an effective way of keeping the disease under control, so that what we're aiming to do in unfortunate people who are often struck down by these diseases, without any warning, and it can be pretty devastating. We try and control the inflammation, induce a period of remission, and that may require these drugs or in combination as maintenance, so that we keep the patients healthy.
Perfect. Thank you so much. A very comprehensive overview to the medical treatment. I guess the question that comes to my mind from that is, how is the most suitable drug chosen for a patient? What factors need to be considered?
Great question. It's an evolving area because we don't necessarily have a definitive answer. We often have a range of potential treatments that we need to discuss with the patients, and sometimes their requirements are different. Some patients hate the idea of injections or intravenous infusions. Other patients are quite happy about giving different treatments, like a diabetic EpiPen, a pen, and they'll just be prepared to administer that treatment every week or two. Some patients really like having an oral treatment, because some drugs have been around longer than others, so that if we're seeking a balance between efficacy, effectiveness, and safety, we might have more information about some of the older drugs. And for some patients, that's very important. They don't want us to be using new or experimental drugs. But equally, there are some patients who've been around the block a few times and who've tried various drugs, and they the clinic and they say, "What's new, doc? What have you got that will enable me to avoid potential surgery or will improve my quality of life?" How we sequence these drugs is absolutely a really, really good question. It's pretty central to what we do. I would like to say that while we may have a view of that and discuss that with the patients also have a view, and this is an area where a discussion between the doctor and the patient really helps, actually, often.
Perfect. Thank you very much. And I suppose as well, another question people might have listening to this is, given the wide scope of medication available, when is surgery recommended, or when might that be the best solution for a patient?
Yeah, I think that's a really, really important question. There are 3 areas, but it turns out that with Crohn's disease, probably about 75 or 80% of people need some sort of surgery at some stage in their disease. With colitis, it's much smaller than that. Maybe 20% of people need an operation. So it only affects a minority of people, but nevertheless, there are 3 different scenarios. The first is the small group of patients who have really severe, life-threatening colitis. We call this acute severe colitis. It requires inpatient admission. It requires intravenous drug treatment. People get malnourished. The colon can literally go into sort of meltdown and stop working and dilate up, and there could be a risk of perforation, which obviously is pretty dangerous. And so there are a small number of patients who need surgery for acute severe colitis.
Mm-hmm.
Drugs work about 3/4 of the time, and then the biologics work. So it's only a small number of patients, maybe 10%, but occasionally. The second occasion where people need surgery is where we've been using various drugs, often for maybe a few years, and they're not really giving the patient the quality of life that they want. The disease can be still active, the drugs maybe aren't working or are causing side effects. And sometimes a patient walks into my clinic and says, "Doc, I've had enough of this. I want the colon out. I want surgery. I want to be shot of this disease." So that's okay. That's an indication. And the third situation where surgery is indicated is when we worry about cancer. It turns out that colitis is a risk factor for colon cancer, not immediately, but after about 10 years. And there's a really important part of looking after our patients is what we call surveillance, which is endoscopically, that means with a camera, looking at the inside of the bowel for kind of worrying changes, because you can pick up precancerous changes before they become cancer. Really good argument, by the way, for people keeping contact and having surveillance. And if we see worrying features, if we see dysplasia, which is a kind of pre-cancer condition, or if we see certain other features, then that can be a reason to suggest to patients that really they're much better off having an operation.
Perfect. Thank you very much. I'm sure a lot of patients will probably ask this question prior to surgery, but is it a definitive cure to ulcerative colitis?
Yeah, again, a very good question, really. I would say it can be, all right? Mm-hmm. So two common scenarios. Okay. There's a procedure called an ileoanal pouch, which it's a bit of a mouthful, and indeed it's a hell of a thing to go through, because the people who opt to go for a pouch, they usually go through a first operation to remove most of their colon, which makes them feel a hell of a lot better because 90% of the inflammation is taken away. But it usually means they have to have a bag, a colostomy. And the rectum, the last bit of the bowel, just above the bottom, is left in place. That's often enough to get people out of danger and to settle people down. Then in the second operation, they have this artificial rectum, this kind of stool reservoir constructed from their small intestine, and that's what's called the pouch. So take a bit of small bowel, you model a little reservoir, you plumb it onto the internal opening down below, and you still usually have this bag while everything settles down. And then finally, the third operation is that everything's connected up so that you've lost your colon, but you have your small bowel joined up to your anal canal, and you're able to go in the normal way without having, which is obviously pretty desirable for most people. And although there's a bit of adaptation, and people often find that the pouch takes a while to settle down, and they go to the loo quite a lot, at least for the first few months or 6 to 12 months, that they get a really good result, and it takes away their colitis. Just a few people, often the older age group, require the first operation, the colectomy, and then they're so pleased and they feel so well and they're happy to exist with a bag because maybe their various issues in terms of body issues or relationship issues or sexual function aren't as preeminent a concern. They say, you know what, I'm doing really well with this bag and with the fact you've taken away 90% of my colon. I don't need more surgery. I just want to carry on and get on with my life. And that's often an indicator that surgery obviously is intended to improve quality of life. It can result in a cure of the disease. It's not to be undertaken lightly, but it's a really good option for some patients.
Perfect, thank you. And we're on to the final question. And I think it's probably one of the questions that people would have very often, and it is, what is life like post-surgery? So I imagine because it's such an intense, all the procedures that you've mentioned are very intense and invasive, that the recovery period is prolonged.
Well, it's a great question again, and it's the obvious question a lot of people want to know. It kind of comes in a couple of situations. Like, if a patient is really sick with an acute flare of colitis, then surgery is life-saving. And very quickly, people, even if they've lived with their disease for not very long and it's really traumatic, will wake up feeling better and have a really good post-operative course. In the more long-term, we would say chronic phase, where maybe somebody's been living with their colitis for years, having an operation usually results in a transformational quality of life. So I mean, I had a taxi driver last week who obviously his working life was really, really influenced by bad attacks of ulcerative colitis. Couldn't work for long periods of time, had been near lose, etc., etc. But the operation put him back into normal working, and it was transformational, and he was very grateful to have had it. So I would say that surgery is intended to improve quality of life, but now with keyhole surgery, the recovery is often much quicker than it used to be. There are big, huge cuts. Amazingly, I mean, this is anybody who knows anything about biology will say, hang on a second, it's all very well telling me about keyhole operations, but the colon is like this long, and it's pretty thick, and how you can get it out? You can get it out through not a tiny incision that big, and you can fish it out via a keyhole approach, so that you wake up after an hour and a half surgery with a few small incisions. You're in hospital for 4, 5, 6 days. You go home. You take a couple of weeks. You're probably back at work or back doing your normal activities within 3, 4 weeks. So the recovery is usually pretty quick and marked by feeling a lot better than people were before the operation.
Well, perfect. Thank you so much. It's amazing what can be done to improve health. Professor Bloom, that's all the questions I have. So thank you very, very much for your time and for sharing your expertise with us today. We really, really appreciate it. And to anyone listening or watching, if you would like to book a consultation with Professor Bloom or any of our leading consultants, you can do so by visiting the Top Doctors website. Thank you so much.
Thanks, Lauren. I enjoyed it.
No problem.